Good evening, everyone. Thank you for joining us. We are here tonight for In the Loop, and I am proud to introduce you to Andy Brittingham. He will explain to you all that he does. He works for Accent Care, and I will hand it over to you, Andy.
Thanks, Meredith. Hi, everyone. So I'm Andy Brittingham, and one of the hospice liaisons for Accent Care. We do hospice and palliative care all throughout Delaware. I am locally based here in Sussex County, right in Rehoboth. And Meredith, thank you tonight for inviting me to come speak. Tonight, I'm going to talk a bit about hospice and palliative care. I'm going to do my best to help dispel some of the myths behind what we might know behind hospice. Some people like to call it the big H. They don't like to say that, but also talk a little bit more about palliative care, since that's a bit more of a topic that more and more people are starting to hear, and that's starting to spread a bit more in the community. Um, the slideshow I have, I'm just using it as more of a focal point. I use this when I'm talking a bit about Accent Care and who I work for, but the two topics in general, they're going to be across the board. I know we have some folks that aren't in the state of Delaware and different parts of the country tonight. So this is kind of a universal thing that we can go through. I'm going to go past our vision. So let's talk a little bit about palliative versus hospice. I'm just doing a side-by-side breakdown of the two to start off. Um, a lot of us have heard about hospice, but on the palliative front, palliative falls under that hospice umbrella, vice versa between the two. When we think palliative care, it's across the board for illnesses. It is there for people who have long term chronic illnesses, who have serious issues. It's there for people who are starting to or continue to experience issues such as stress, pain, discomfort, poor quality of life, more or less. It's there as a backup. So you've got another advocate that's on your team other than just you, your family, your immediate friends. It's somebody that's on the healthcare side that can be there to help speak on your behalf. Palliative care is provided generally by doctors and nurse practitioners. We also do have physician assistants. That separate side, we call those advanced practice providers, but those are the most common folks you see that are providing palliative care. On the hospice care front, a little bit different. It's a step up from palliative. When we get in the hospice front, it is not simply giving up. That is one of many things that I hear. There's a lot of tough things when it comes to hospice, but it's really a bit of a shift. And I use a lot of analogies in this job and how I explain the two. So we'll try to have a little bit of smile and laughter and as we go through this as best as we can. But hospice is there to step in a couple of different scenarios. When, for example, say you have been to a healthcare provider and they feel that you may have a very limited window of time left. Um, in particular, they wouldn't be shocked if you may not be here 6 months from now. Another alternative may be that if you're on a certain treatment plan, if those treatments are not effective or they're not helping you any further, in the cancer world, for example, if you've been getting chemotherapy or radiation and you have a healthcare provider that's been looking at your scans and sees that those treatments really aren't doing justice for you, that might be another option to consider hospice care. The biggest focus on hospice is quality of life, providing comfort to our patients, providing support from for our loved ones as well, because they're the ones that are there to help get us through such a tough time like that. And it's focusing on our emotional and our spiritual needs as well. The team is kind of similar with hospice, but beefed up a little bit more. So, similar to palliative, there are doctors very much involved in hospice care, but also there is nursing staff, nurses' aides, such as home health aides or CNAs. We have a chaplain or chaplains, plural, that are on staff. We have social workers. There's even volunteers and music therapists for our hospice program as well. So we'll do a little bit of a deeper dive, and I'm going to start with palliative care in particular. So when we get in the palliative care arena, think of things like cancer, think of heart failure, think of COPD. It isn't just one particular illness. Sometimes you're starting to see palliative stepping in when people have one or multiple issues. Doesn't have to be the whole laundry list. Oftentimes, we're seeing people juggle a lot of different ailments. And when that's happening, we're also running back and forth to the pharmacy a lot or having to juggle a lot of medications. When we're battling illnesses, oftentimes it's getting tough to manage our symptoms. We may be focusing on issues such as weight loss. Other times, we might be looking at hospital trips, excessive trips in the hospital, and maybe not really sure what we're doing. A lot of times when folks are getting a referral to palliative care or the option of it is coming up, people really don't know what to do or what's going on. Um, Palliative in particular, you're seeing it not just as a formal drop-in home visit. Within the last 5 to 10 years, we're starting to see hospitals implement palliative care as a discipline because we have so many people going back into the hospital systems for different issues, whether it's symptom management, um, in particular, people having reactions to chemo, radiation treatment. Palliative is there in place to be another layer, to really be an advocate to say, hey, what are we doing? Um, I'll use one example. I worked in the hospital world for a number of years. I had one patient that had a remarkable 41 hospital admissions in 5 years. And we were just starting palliative at the time when we got in front of her. And we got to her and said, what's going on? What's bringing you in here? It's more than just your symptoms, it's more than just the nausea. What are your goals? Palliative care is often the start of goals of care. And I'll talk a little bit about goals of care between the two. I do a lot of it on the hospice front, but it actually applies in both worlds. A lot of people don't know what their goals are when they're facing serious health issues. And sometimes they're thinking in the short term, they're thinking in the survival mode. Some haven't quite made it to the long term front of what they want to do. Do they want to keep going back to the hospital? Do they want to treat their symptoms or not?
Pardon me, Andy. Will
Yeah,
you
go
speak
ahead.
just a little bit louder? Some people
Oh,
are having
sure.
struggling to hear you.
Is that any better?
Yes. Sorry. Thank
Yeah,
you.
but that's okay. My laptop sits a little bit lower. I can turn my volume up on that. Um, Palliative is there to help try and start tackling the key issues of what's getting us in the hospital systems, what's getting us to keep coming back for more and more care, and figure out what we need to do next and make sure patients and people that are seeking care get what they need. The biggest focuses on the palliative front are making sure A, your symptoms are managed. Comfort's the key thing. My nursing brain shifts a little bit more. We want to make sure you can breathe safely, you're comfortable, and you're safe. Palliative is there to also make sure you're a little bit more satisfied when people are coming in for healthcare, whether it might be at a cancer center, physician's office, hospital, or wherever. Oftentimes, they're juggling it while trying to juggle life. They're adding in one or multiple doctor's appointments, treatments, you name it. Palliative is there to try and get goals in line to figure out where is it important to be seen, what's important to you when you're coming in for these visits, and do we need to have multiple appointments scattered throughout the week? Do we need to do it all in one day? It also is a great stepping stone to figure out what your choices are as life goes along, and sometimes just to stir up that pot to figure those things out. When I talk about goals of care with patients, two key things that I talk about real early on, and it's the elephant in the room, let's get it out of the way. I want to know what people want when we reach the end. There are three definitive things in life, death, and taxes. We all hate the third one, obviously. Life happens regardless. But why don't we plan a little bit when the end does come? We don't have our date of when we're going to pass tattooed on our foot, at least not that we can see. So we might as well let our patients be empowered to let them start thinking about what do they want. Is it a scary topic to bring up? Is it something that they've been facing? We want to know what they want. We talk about things. We use the term code status in particular. Code status, kind of the down and dirty version of it is if something were to happen, say if all of a sudden your heart were to stop, are we going to try to revive you, or Do you not want that? Do you have friends and family that are aware of these wishes, or is this something you want to keep to yourself personally? We can kind of go down a rabbit hole from there, but that is something else that we like to talk about in palliative care so our patients can be empowered so they're in control of this entire journey. Symptom management, though, at the end of the day, is really the key one. When we start peppering in more and more medications, more appointments, and also everyday life, it's very easy to get overwhelmed. And it's very easy for those that we're working with and taking care of just to be sitting with the symptoms they experience. So we always like to talk about it. We want to make sure pain is a focus on the forefront and helping to manage it as best as we can. I'm gonna go back for a second. I'm not gonna hop off palliative yet. Um, for palliative across the board, depending where we are, whether we're here in Delaware, we're in Michigan, we're anywhere in this country, couple different settings for palliative care. A lot of times we have folks that are met at home for palliative care, where a palliative care provider comes to them to do things in their home setting. Could be a house, apartment, assisted living, nursing facility, you name it. Um, we come to, I don't like using the term institutions, but assisted livings, long term care facilities, um, skilled nursing facilities. We come there because palliative also follows people there. Hospitals as well, that is the newest forefront. We're getting a lot more palliative care in a hospital setting too. So it is in multiple different layers. It's coming to patients wherever they are. We even have outpatient clinics. A lot of the hospital systems do have outpatient centers locally here in Delaware. BB, Bay Health, Christiana Care, and I say Nanticoke, but Title Health Nanticoke, they all have local palliative care clinics that patients can come directly to for what they call outpatient palliative care. Many of them are also embedded in cancer centers in particular. Palliative is a key part in a lot of cancer settings as well, again, to make sure symptoms are getting managed and there to aid patients along their journey on top of that. On the hospice front, kind of the next stepping stone. I have several slides on hospice. I'm going to go through this part, the slides at least a little bit quicker. Again, I just touch on the topic, but the hospice front. Hospice comes after palliative care. And on the palliative front, there is no set time frame when it comes to palliative care. Again, one illness, multiple illnesses are the most common one that we see, but folks can be on palliative care kind of a never ever ending amount of time. There's no set timeline on it. Oftentimes, it's up to patients and direction from healthcare providers of when hospice would be the next step. So, hospice will usually step up or be the next option that's presented when we again are at that point that treatment options may not be on the table any further, when folks are having symptoms that are unmanageable in the setting that they're in. I have some folks that perhaps may not want to go through treatment. Perhaps they have a poor diagnosis. Doesn't just have to be cancer. Perhaps they have severe heart failure and a poor ejection fraction. Maybe they have lung diseases, any type of lung failure, COPD, mesothelioma. Maybe they don't want to have to keep going back and forth to the office to be told the same thing, to keep getting the same inhaler. Sometimes people just want to kick back or be left alone. Some people want to enjoy the company of their friends and family. Some people want to maybe just go out and do lunch every day for however long they have. The choice is theirs when it comes to hospice is the next step. Hospice does not mean giving up. It's really focusing on the comfort pathway. So how does that look? What does comfort look like with hospice? When hospice steps in, the team comes to the patient. Most situations, we are coming to them at home. And for folks that are in other types of settings like nursing facilities, assisted livings, long term care, memory care, hospice comes there as well. Hospice is a 24-hour operation. It's not just, and not in a bash of any way, but it's not like home health hours. 24 hours a day is hospice. If you're having urgent issues in the middle of the night and need to start hospice, most hospices can support that. If you just generally need to have education to make sure it's the right step for you, hospice can come out and educate. It's not giving up everything. When you come on to hospice care, you are not stopping all of your medications. It is not pushing that gas pedal to push you closer to the end at all. It's there to support you. The most common person that you would be seeing on the hospice front is our nurses. So, our nurses are the ones that steer the figurative ship for you. They help put our patients in charge and in power of how their journey looks. They're there to help manage the pain if it's happening, manage any symptoms, or start to plan out what to do in times of stress or symptoms, and really get a full picture of what's going on and how we can help. My biggest push when it comes to hospice care is talking about it early on. We're talking about it today. This is a big leap for a lot of people because it is, again, a very fearful thing to even think of. This does not mean you're signing your life away either. Hospice is there as much as you want it. I've had some folks that come on board with us and only want a nurse and nothing else, and as little as possible. That's fine. Medicare guidelines generally say a registered nurse has to see patients once every 2 weeks. We can't just show up once and not come back. But we need to come out. We need to keep eyes on those that we're taking care of to see what's happening from visit to visit. That way, we know what to do medication wise. We can help build a bit of a stronger relationship as time goes along as well. And perhaps stepping up visits, that's the next thing too with nursing. Most commonly in a very status quo, middle of the road scenario, your hospice nurse comes out about once a week. They're there to get a big look at how are you doing? How are you feeling? What are your needs? And to be there for any topic that might come up. That first visit or two might be a little bit weird. Yet another stranger coming in, somebody else from healthcare. But that nurse is there for you and to advocate for you. After hours, nights, weekends, we've got nursing availability, all hospices do, that can be there to advocate for you, whether you have nausea that suddenly starts flaring up, if you start having pain that you don't know what to do about. Hospice can be called 24 hours a day. In most cases, we are generally sending out what we call a comfort pack. We put comfort medications in patients' homes. Obviously, we check the scenario before we do it and we make sure it's a safe plan to do. But we try to prepare those that we're caring for to have things on hand, almost like a mini Walgreens sitting in their fridge just in case it's needed for those times of crisis. I have some folks that use it, I have some folks that never touch it. Doesn't matter which they do, as long as their symptoms are managed and they have access, that's what counts. Nursing helps educate family, loved ones, caregivers, whoever else is involved to figure out what to do, who to call in those times of need. We always say to those that are living under the same roof or there as an advocate, call us at any point. It doesn't matter what the question is. No question is silly. We'd rather something be brought up and be able to get ahead of something before we have a pain crisis, a symptom crisis, before it turns into an urgent matter. A lot of times with early intervention of both palliative and hospice care, we're starting to see fewer and fewer issues where we have urgent calls. Even when we have after hours calls with the early start of these programs, usually it's things that are a bit more manageable. We're starting to know our patients a bit more. We know what they need. We know what they're sensitive to. We can start to understand what's going on with them, family, friends, find out how to best support them. Beyond nursing, there's a lot more. This is where I get a little bit wordy, and I'm going to hop on I'm going to put the whole circle in front of me for this. Beyond nursing, we also have, or hospices have, social workers on hand. They can help with matters such as aligning maybe additional help at home, getting you connected with resources, essentially for advanced care planning, for things like looking into wills, setting up trusts, setting up other important healthcare documents, or being there to do things such as legacy projects. I'll talk about that one a little later on. That's a cool one to talk about, though. We have chaplains that are on staff, non denominational, totally optional. They can be there for you or connect you with somebody that's out in the community. Doesn't always have to be a spiritual or religious thing. Sometimes it can just be there for the social connection as well. Some hospices do provide different types of therapists as well. At Accent Care, we have music therapy in Delaware. I'm pretty sure we're still one of the largest employers of music therapists throughout the country. I know we were about 2 years ago, but I haven't heard that statistic come up in a bit. Um, but you may commonly run into things like music therapy. There's also art therapy, pet therapy. Every hospice program is a little bit different to those types of therapies that are on board, but they can be there also as an added support because some of us have our fill of people over time. Sometimes we need to just sit back and enjoy music that keeps us calm, or a furry friend to come pay a visit to give us a little bit more of a smile and take our mind off of the big picture of what's going on. Sometimes when you have those distractions of art and pets or music, you're not always thinking of what's happening in the moment. We distract ourselves with other things in life. Sometimes we need that distraction when we get to a point of hospice care. On the hospice front as well, not something a lot of people always use, but a great person to have on hand are our valuable hospice aides. And I also have to give a shout out for anybody that knows one. This is Nurses Aid Week from the June 11th through June 17th. So if you know a CNA, please give them a shout out this week. This is their week. It's a great week to shower them with cake and goodies and probably Diet Coke to stay awake. But the hospice aides are a great tool to have, especially for personal care. I'm going to shift away from the cancer side and I'm going to shift toward a COPD patient that I work with. I had this one gentleman who was your classic curmudgeon, did not want anybody near him. He only got along with his nurse because they were both Eagles fans. So that was an immediate allow to come into the house. They both agreed on that. He didn't want anybody else coming in there. And this gentleman hadn't seen a shower in some time, but that's okay. Sometimes that happens with people. It took a lot of trust and it took a lot of talk about a Sunday game to convince that gentleman to allow our nurse's aide to come in to see him, to help him. And I kind of hate to say forgot, but I didn't really listen and hear what was going on for about 2 weeks. And all of a sudden I noticed, because this gentleman did happen to call us a lot with issues going on, we noticed the calls dropped dramatically. We were not getting calls nearly as much after hours, and during the day, the calls completely stopped. Lo and behold, the biggest difference that this gentleman had was he had somebody that actually came in and got him cleaned up. And no, they did not come in and just immediately push him in the shower. Our nurse's aide at the time, still remember her quite well for doing it, she came in and sat down with him just to talk with him to see what he was comfortable with to start. And that was a big stepping stone, especially something that personal when you're getting undressed in front of somebody, getting in the shower, sitting on a toilet or wherever just to get cleaned up. If you think you've been vulnerable, it's even more vulnerable at that point. Um, our nurse's aide did wonders with him, got from doing just simple hand and nail care on day one and getting some lotion on him to a week later actually getting him the courage to help him into the shower to sit, to get him cleaned up. And we found out his biggest fear he didn't open up about was passing out in the shower. And what had started his journey to get to hospice was he had passed out in the shower because he couldn't breathe. He was end stage COPD and was fearful of the shower even before this happened because he didn't want to have an accident in there. And that's what happened. So luckily our nurse's aide was able to juggle the bathroom fan, an open window, an open door, and still kept him with oxygen while he got cleaned up. And he looked like a new person. And he actually had quality of life. And when I met with him, sometimes we put a rough estimate. We're not sure how long we have with our patients. I didn't think we had long to have him in this world. And I'm saying like weeks. He actually was with us upwards of 9 months, and I was quite impressed it went on that long. Um, the same nurse's aide had him for every visit. She actually stepped up into a new role and still volunteered to come see him at the end of her day as the last patient that she kept on as an aide. So I call out little quiet success stories you never hear that go on, but things like that make a huge difference. Other folks on the team that make a big impact as well. Most hospices have volunteers, all different walks of life. I'm a big fan of volunteers because, again, the social aspect. Sometimes it helps to have that person that's not your friend and not your family member, somebody else just to talk to. For our veterans, for our people that have been in healthcare, it's good to have somebody that's there that may have had the same background. On the military front, very different language when you've served. It's nice to have somebody else that can be able to speak the same way or reflect on stories on top of that. Also in hospice is the physician. That's a big one that takes a little bit of comfort for some patients. Others are ready to rip that band-aid off to have their own doctor. When people are going through treatment, especially when they've been going to a cancer center or going to specialists for a long time, we form bonds with people in these centers and these healthcare centers. We have a tough time disconnecting from them because it's a change that maybe we're not ready to do. On the hospice approach, for ours in particular, we say it is at your call when you're ready to step away from your own healthcare providers. We call them in the community because it's a difficult thing. Every hospice is a little different. Some may say you need to come completely over to theirs. Luckily for us, we give you that choice. We're kind of at that bridge where if we're stopping treatment, there may not be the best reason to go, but if you need perhaps a goodbye visit for some closure, that's absolutely fine. If you still want to be able to pick up the phone, if you still want to have consults, you should be able to do that. When it comes to hospice, we have our own physicians that are there to advocate for, to see, and to prescribe for our patients. Think of it as a whole umbrella again, coming to our patients so they don't have to do the legwork of going out to be seen. The nice part there is when we've got our physician on hand, if we need to prescribe a medication or do a change at any hour of the day, even, a little bit of hairiness, not having a 24-hour pharmacy readily available, we can make it happen. And we can have that guidance around the clock, having a hospice physician on hand to give some guidance. Helps bring fear down in patients, helps bring fear down in families that are caring for them as well. I put next to the circle, I have some mentions of just some myths that come up when it comes to hospice care. It does not mean giving up by any nature. It's really putting a lot of control back in our patients' laps because a lot of times, piece by piece, they're giving up a little bit of their own control, whether it's coming in for a visit or a medication that they have to have or a pharmacy they have to go in. We're putting control back in your lap of what you do. It's not just for cancer patients. I fed you off a little litany of diagnoses, for example. Dementia is another big one as well that we do see, but it is not just a common cancer thing. We're getting it a lot more in heart failure. We're seeing it extensively with dementia patients, especially stroke victims that are continuing to age and affecting their vascular system over time. It's not just a one size fits all. Former president, I believe it was Jimmy Carter, the one that had just passed recently. He was a prime example, and kind of also the timeline too, because I'll talk about the timeline with hospice care. He was another one that had the opportunity to be on hospice, and he wasn't your typical cancer patient. He had a litany of health issues going on. He also outlived what we typically hear for a 6-month prognosis. He lived just over a year. Um, it varies for everybody. Not everybody's the same. Not every diagnosis is the same. So everybody is treated individually. A plan's made up for them to make sure they get what they need. And also about where they're getting care, hospice goes to where our patients are. Each hospice service may have a little bit of a different requirement. In our case, we go anywhere our patients are. About 95% of our patients throughout the state of Delaware are in a typical home setting, whether it be single family, townhouse, apartment, or whatnot. The other 4% are in facilities such as skilled nursing, assisted livings, memory care, and then two other outliers. One I always talk about in our case, just for who I work with, we actually do go to those that are homeless. That is one population that varies heavily on hospice. We will do it. We've worked with the Pallet Village in Georgetown. I myself have vouched. I have gone out under the interstate in Wilmington before to go to our patients. Fun little challenge, but we go to them. We're always working with them to try to get a safe housing solution as well. But we go to our patients. We want them to be as comfortable as can be and get them care wherever they are. Um, and then the other spot that we do care for patients are in hospice units. I'm going to talk about hospice inpatient units as well. I didn't mention the myth part about that, but I'm going to talk about that too to dispel a little bit of what hospice centers look like too. The next one I have, I talked a little bit here just about different programs my hospice has to offer, but depending where you are and at that point in life, if you ever do need hospice, it's always important to ask about what programs a hospice has. Everyone is different, but at the same time, all hospices have to offer the same nursing, social work, aid, and physician services. There are always some a little additional programs that make situations unique. For us, we have legacy projects, a veterans program. We have two dedicated side ones as well. We have one that focuses on Jewish values and traditions, particularly heavy in our New Jersey program outside Edison. And then Namaste Care is another one where our nurses aides are specifically trained to help in a Namaste protocol in caring for patients. Another cool one that we do is open access, where there are sometimes that we're able to provide some expensive medications that may not be common on hospice, or perhaps some degrees of radiation, depending what's going on with patients. That's always something that's addressed case by case. But again, should you or a loved one get to a point to need hospice, it's always important to ask about what else is provided so you know what's unique to that program. I had talked about legacy projects, and these are two examples that I wanted to show tonight. Some of us may have crossed paths with it with our loved ones before. Our memory bears are the most common ones that you see. The one on your right that is decked out in pink and all sorts of 90s colors. Our memory bears can be made from all sorts of different types of fabrics. When we have patients that pass, we have families that donate things like clothes, like blankets. I've had, we had one that actually donated a portion of a piece of the clothing from their service in the military so we could make a camo bear. But we like to do memory bears as a keepsake. That way, our loved ones have something important to hold on to that is always there for them. In particular, we're gonna have a soft moment. I'm taking away being the nurse here for a moment. I'll go on the personal aspect. I lost my father in January, and it's very tough to divide the two roles. Like, you know what you're doing as the hospice nurse, but at the same time, you got to be son, you got to be caregiver. The divide between the two is a little bit of a difficult one. And we had a family member that was very, very involved with not particularly memory bears, but bears. My dad never told me he loved the miniature bears that she had, and she wanted him to go to the hospice unit with one of the bears that he was fond of. And we very quietly, after he passed, picked a couple pieces of his clothing that I knew meant something to her. And we actually made two memory bears, one that we gave to her, where she's always got that keepsake close to her heart that will forever be there, that will sit in the bear collection to be there as a keepsake for a lifetime. And if you can see carefully, depending on how big your screen is, if you might even be able to zoom in and see it, on that bear is a necklace. So one of the things a hospice can do, they can do other keepsakes like necklaces, like keychains, and on that necklace is actually a thumbprint. So this was a sample one that we did. It's actually my thumbprint that's on there. Don't zoom in too hard, but hospices can do things like that. So you have something like a thumbprint as a keepsake as well. The hands on the left are a unique one. So we had one volunteer about a year ago that did clay models, and they actually did a clay cast around a couple's hands. They had just celebrated their 60th wedding anniversary, and so many photos that their loved ones took of them, they were always holding hands. And the spouse always wanted to have them holding hands through the end. So one of our volunteers and social workers actually helped do this cast mold and made it. This is just the dry version of it. I didn't get a picture of the final product, but this was one of the examples of a project that we did. So family had a keepsake to carry on for life as well. When it comes to either side, palliative or hospice care, a couple of different things when it comes to talking about it. I put the term refer here, but this is really when does it need to come up? When do you need to talk about it? Bullet points are frequent hospital trips, if there's been a change in health, particularly a decline. Think of things like weight loss, appetite's not happening, you can't eat like you used to, or your loved one can't. Perhaps there's an issue of addressing what those goals of care are. What are we trying to do? Are we trying to focus on getting curative treatment? Are we trying to focus on being comfortable at home? Are we trying to hop on a Norwegian cruise for 3 weeks and go have the time of our lives? Things like that to try to figure out what your goals are. And sometimes you need to have a person on the outside be the one to help address that for you at the end of the day. Symptoms as well. Symptoms if they're not being well managed, and if your treatment plan isn't working out in your favor, no matter how many pathways you go. And when it comes to getting a referral or even just talking about palliative and hospice care, it's not a commitment that you have to do it. It's good to have the discussion tailored specifically to you to figure out what might work for you or what might be the next best step. And I apologize ahead of time. I have a lovable golden retriever and I have a feeling he's about to bark in the next 90 seconds. So if you hear some barking, please ignore that. Anybody can reach out at any point for hospice and palliative care programs. You don't generally have to have a referral come in from a healthcare provider. If you do elect to move forward and want to be seen by either of those programs, usually the service that you work with, they'll take care of that for you. You can generally call in, like for us with accent care, I've had folks call my cell phone directly asking questions or just wanting me to come out to their house in 20 minutes to figure out what to do and what next steps are. Um, Anybody can make the call. Anybody can ask questions. Anybody can be that referral source to get the wheels moving. Of course, the dog barks. I timed that one well. Um, Back to where care generally happens when it comes to palliative care. Again, multiple types of inpatient and outpatient settings are your most common thing for palliative care, and hospice can come to you at home, assisted living settings, nursing facilities, and inpatient units. That'll be one of my latter slides I touch on as well. When it comes to payment, obviously, we're in a lovely world with insurance. Hospice programs are covered fully under Medicare. So, for those of you that may have Medicare, your Part A coverage, which is your hospital benefit, that's what pays for hospice services. If you happen to have state Medicaid, Medicaid plans will pay for hospice as well. When it comes to private plans, it varies. Everyone's a little bit different, but when you get to that point, if you need to approach it, the hospice and palliative provider can talk to you about what insurance looks like for that. Palliative care looks a little bit different. Palliative care is treated as if you're going like to a physician's visit. So whether We're going to use some local examples, whether it's our program with accent care, say if our palliative nurse practitioner is seeing a patient in a nursing facility, or if you're going to palliative care over at Tunnel Cancer Center. Perhaps you're being seen by palliative care in the hospital. Palliative is treated a little bit differently, treated like a physician visit, also can be billed that way. Again, varies on your insurance. For those people that don't have health coverage or are underinsured, hospice programs do have charity programs and no cost options. That's something that can always be asked. We never want that to be a deterrent. I've worked with a lot of folks that unfortunately are underinsured or uninsured, and we've been able to get them the care that they need. That's not a holdback at the end of the day. I did, I left this on here just as a glance. You kind of get hospice all over the country. For us, we're scattered about. We're particularly heavy, luckily, here in Delaware, Maryland, New Jersey, and Florida. But I bring this up as an example because where we are, especially for Delaware Breast Cancer Coalition and the state, we get a lot of snowbirds here in Delaware that tend to flock south in the wintertime. We do see some of our patients that have been on with us that are getting ready to head south for the winter, or vice versa, coming back from the Florida area in time for the heat here. You can move around. I do not, when you come to hospice and palliative care, you're not stuck where you are. You don't have to stay in the one place. Luckily, you can get out and shift a bit. And I'm going to talk a little bit about that too toward the end without a slide involved as well. Um, Inpatient units. So I have examples of what we have for our inpatient units. There are a total of three inpatient centers here in the state of Delaware. So Accent Care Hospice, we run two. We run one on 6E at Christiana Care Newark. We also run one on 3 North at Wilmington Hospital. Delaware Hospice also operates the Delaware Hospice Center in Milford, about a mile and a half, 2 miles behind Walmart. Almost all hospices have contracts with one another, especially if there is an inpatient unit involved. We have had folks in Delaware Hospice at our inpatient units up north, and vice versa. We've used their hospice center in Milford as well. When it comes to a hospice unit, what happens to end up there is when you're having symptoms that cannot be managed at home. Let me just throw a prime example out there. So let's say Jane Doe's family calls me at 7 p.m. on Saturday night and goes, "Oh, holy smokes, Andy, I don't know what to do. She is screaming through the roof. She just slapped my son. I don't know what's happening. We tried to give her a shot of vodka." This has happened, honestly. We tried to give her a shot of vodka and it didn't work. We coach our families ahead of time. We try to say, let's look at pain medications. What have we done? In her case, nothing worked. Unfortunately for that patient, she was having breakthrough pain, and her medications at home were not touching the pain. So at that point, we talked with the patient. She was still able to make decisions, albeit very uncomfortable. We talked with the family who was there with her. Choice was made to get her to an inpatient unit to get her symptoms a little bit better managed. How that usually works, most commonly, we see IV pushes and sometimes IV drips to help manage pain. It's around the clock nursing oversight as well to help our patients have their symptoms alleviated and figure out if we need to add something new to their plan or if this was just a one-time issue where they're having symptoms pop up and get them addressed to move on. A hospice unit is not meant to be thought of as a place where you go to die. Do we have folks that go there that do pass? Absolutely. It happens. There is no denying that. It happens at Delaware Hospice Center. It happens at our inpatient units. In particular, at Newark, most of us are familiar. It's the largest trauma hospital in the state. We get the sickest of the sick. They get transitioned to our hospice unit there because that's the next most compassionate step for them to be comfortable. Do we have folks that get discharged from there? Absolutely. I cannot tell you how many times a day I look at my emails and I see transfers of folks being discharged from our unit. They've had their symptoms managed, they've had whatever need that needed to be addressed, taken care of, and they get just discharged to their next destination. Hospice units, generally any hospice at all, they are around the clock. Family and friends are welcome to come. Obviously, it's up to what patients can handle and what's going on in the moment, but we don't shut them down. We want family to be there, especially if it might be a situation where a loved one is passing. We want you to be there. We want you to be comfortable. In hospice units, at least the ones in Delaware, they are all private rooms as well. So you're not having a semi-private or two-bed situation. Personal situation for me, when I had dad dying, I was in the hospice unit with him for the first 2 nights. I stayed there until I just had to take a break and step away and be away from there. There's no limit at hospice units. You can be there as long as you need to. Another one that I brought up specifically to accident care, but also does take place with other hospice programs. We do have camps that are meant for children. So there are, and again, varies on the hospice program, but for the kiddos that are still processing what grief is and what loss looks like, hospice programs do have camps that are set up and that go on throughout the year to help kids understand what dying is like, what grief is like after the loss of a loved one. And depending on the time frame, it helps them go through activities and meet up with other people their age to be able to compare stories and even make friendships in the end out of it. So this was one of the kids we had in 2024 when we did it over on the eastern shore of Maryland. But we've done a couple here in Delaware, and sometimes we'll hop around locations. So camp's a little bit of a different experience every year. Another, actually, let me bounce back for a second because I have one I forgot. When I talked about bouncing around with hospice, I have made my little humor. I want people to be able to do what they want. If they want to be on their couch and watch Price is Right, if they want to go hang out at the diner and have coffee and pancakes every day, I want them to do what they want to do. Same goes with where they're getting their health care. For our folks that travel throughout the year, we do see it commonly that they'll start care in one location and come somewhere like Delaware and vice versa. Hospice doesn't have to be a permanent thing. Patients have a choice. You do not sign your life away. Same goes with palliative care. Either at any point, if you feel you're at a point that you don't need it, or this is just the time to stop, you stop. If you want to come back on later, you come back on later. I had a gentleman, because I made a silly joke about a Norwegian cruise. He called me up a couple years ago and said, Andy, I've never been on a cruise. I'm leaving on Saturday. And we did not think this man was going to make it 2 weeks. And we were a little bit panicked, but we honored his wishes. We went, met with him, made sure he understood what went on. Our social worker was phenomenal in it. She actually went and found a driver to get him to the cruise terminal, luckily. He went, he did his cruise, he loved it, and he came back. And during the time he was on the cruise, he came off of hospice. Luckily, medical staff were on the ship as he needed them. And he came back on hospice for another 5 weeks afterward, but he got his wish out of the way. I've had folks that have had, unfortunately, orthopedic injuries. Falls are a common thing that happens, especially as our population ages. That does not stop anybody from going to the hospital. And if they need to have surgery, fine. It's not the end of the world. We're not signing your life away. We want people to get the care that they want to have. If this isn't a fit for them at any point, no matter what agency it's through, palliative or hospice services can be stopped at any point. So again, another thing I always like to put in the laps of people that gives them a little bit more control. I have talked about a lot of topics. I've probably stirred up a couple pots as well. I'm going to put this back on those that are here tonight. If there's any questions, any thoughts, anything that comes to mind, whether or not something I touched on or something pressing, um, anything at all, I'm here for you if you guys have questions, and I'll pass it back to actually Connie. I see your hand popped up. Hi, Connie.
Hello, Andy. I have a question.
Sure.
I want more information on what you said, that if you go into hospice care, they're not stopping your meds.
Mhm.
Okay.
Okay.
Now, I understand that if you go on hospice care and you're taking cholesterol medicine, they're not going to stop that. But don't they stop the meds that are treating whatever illness that you're that is causing you to need hospice care? Aren't they stopping those kind of meds?
Good question to throw there. So, most commonly, depending on what a person comes on to hospice for. So, let's use colon cancer, for example. I'm going to spice it up all over the place. Let's say it's colon cancer. Commonly, the one thing that's not going to continue is any type of treatment along the lines of chemo. Chemo that's treating that is not going to continue. We have patients coming to us generally knowing that it's not a common occurrence where we have to reinforce that. When it comes to medications broadly, our hospice in particular says, if you want to continue your medications, you're welcome to do it. Most medications, I say most, I do not say all, you generally can continue, but the plan is ultimately to wean them down. And here's why. So cholesterol medication is a good one to bring up because depending on somebody's health condition, if they're at a point they're being referred for hospice, and this isn't one to answer, but what is ongoing cholesterol meds going to benefit them for? Oftentimes, if they're continuing with cholesterol meds, it's not going to provide a huge benefit or give them more quality of life. On the flip side, when I have somebody that is on a blood thinner, common things like Eliquis, Janumet, or more basic, like a regular dose aspirin, those are something we weigh carefully to see, okay, is this giving somebody quality of life or not? Is there going to be a cost issue depending on their diagnosis as well? We talk it over with them to see, like, is this something you really want to keep taking or not? What might be an alternative? It's really dependent on diagnosis. Oftentimes, there's other medications that may counteract. The way they intertwine, again, varies on the person. But generally, an admission nurse and a hospice physician will look at it and pitch whatever medications might be of curiosity of, hey, what are your thoughts on medication A, B, and C? Do you want to keep taking them? Do you not want to keep taking them? Again, quality of life, if it's giving them purpose, quality, giving them better days, there's no need to stop it. If there's any type of insurance issue, a hospice can say, hey, this is something we may cover, or this is something that you may have to go through your regular insurance through. Most of the time, medications that hospice recommends and writes for, we will cover the cost for them. But that's always case by case. We write them out in the moment when we can talk it over with our doctor as well. The stepping down or tapering down of meds generally is happening when somebody is starting to reach the end of life. So again, no set time frame. There's the rough ballpark of the month of a 1 month span when somebody's starting to pass, but really more often it's in the days to weeks aspect. I have had folks that are eating full meals and then 2 days later gone, or sometimes it's dragged out over 2 weeks. When we have those patients that are on oral medications, so think tablets, capsules, things that they have to swallow whole, we're also looking to see what their swallowing ability is like and how much they can take down before they could possibly start having a choking issue or if they're having issues getting other things down their throat. Case in point, priority is if you want to eat, we want you to eat. If your Eliquis is more important than your cholesterol med, I want you to take your Eliquis over your cholesterol med because it's not going to do any justice over the next 2 weeks. And same continues to a point where we have folks that then may not eat, which is also commonplace in hospice care. Most folks, when it's not something very sudden, when people do start actively transitioning to the point they pass, appetite's one of the things that does go, and generally over the course of a couple of days, that's where medications are generally stopped as a whole when it comes to whole capsules, whole tablets. And then we transition to more under the tongue meds, and I know I'm rambling, but I can go into detail with that too if you're curious on that one. But we tailor it depending on what's going on with the patient.
Thank you. That answers the question. I appreciate it.
Does anyone have any questions, or you're welcome to turn your camera back on so you can say hello to Andy? There's a lot of DBCCers here, Andy. And I'm going to connect you with Nanny. Nanny, if I can share, she is a chaplain at Nemours, formerly AI. And she texted me and said, "Thank you. I really am enjoying this topic," and I'm going to connect you with her so she can find out more from you.
Okay. Yeah. And if anybody has questions, thoughts, anything that pops in their brain, I'll relate this to meeting with patients and families. Usually it's after you sit and you stew and you think about it, and it'll be, 1 o'clock in the morning and you're like scrolling through TikTok. If you have questions that pop up, this is my email. That's my cell phone as well. Feel free to shoot me a message. You can even shoot me a text. And again, doesn't matter what it might be, even if it's days, weeks, months down the road, if you have anything that pops up and you're just curious, reach out and let me know. I'll be happy to answer it for you. Or if it's something I'm not sure about, I've got great colleagues across the whole industry that can get you in the right direction as well.
Thank you. I think Nanny has a question.
Oh, hi, Nanny.
Hi, good afternoon. I have a quick question. First, my always question. Do you have resources or people that they are available in another languages than only English?
Yes. So we have staff that can, I'll back it on that. We have staff on board with us that speak Spanish and Haitian Creole. We do have literature we can provide to patients in multiple languages beyond Spanish and Haitian Creole. Off the top of my head, I don't have the full list. I know the digital library, we've got at least 10 to 15 different languages.
Oh my
But
gosh,
we also have interpreter services too.
amazing. The other question, I really apologize if for some reason you mentioned this in the presentation. Don't worry, we have the presentation. But question, if there's a good opportunity, I mean, a good way to just try to keep people how to approach to have this information in a little advance, no means that, well, for example, I am a cancer survivor. I'm not thinking in hospice and in palliative care, whatever,
Right.
for the next 25 years. But just saying, if we have a patients that can be worse because it's degenerative, and then it's how is a good way to approach to them to find information, and then they don't need to take decisions just right away because the time go out, and then do you understand what I asking?
I think so. So I'll answer what I think might be right, and you tell me if this works. And if not, I'll tweak it a bit better. So maybe what's the best way to approach somebody that's not going to need hospice or palliative immediately? Like maybe a little bit more on the broad stretch. Okay, perfect. So generally what we do, I will tie this in the same way of the people that have fear around the word hospice, because it's the big H. I've heard everything under the sun when it comes to hospice. Palliative, the nice thing is confusion with that, but I'm starting to get more people that are understanding hospice, both good, but also tying it back to hospice as well. I say to anybody, ask them about what are their goals of care, because that's usually going to stop somebody in their tracks and just look at you and go, what are you talking about? Because goals of care is broad. It's not just hospice and palliative. It's your healthcare picture in general of what are you trying to do? What do you want to do? Again, short term versus long term. And sometimes it's just that dialogue of saying, maybe you need to talk to somebody, a healthcare professional, a nurse, whatnot, about what your goals of care are, like what you're trying to do now, what might be important for the patient, the person you're working with, to know about, what they may need to approach their family about. Things such as like advanced directives. What are we talking to family and friends on? What are our plans? Do we want to keep going to the hospital? But even just talking goals of care, and then if they're not too sure, if you get them in that cold spot, just say, you may need to talk to somebody. I always say, approach it as palliative. Like, you might want to talk to a palliative person in time. Talk about your goals of care and what you may need to do. Because that oftentimes that'll soften the blow a bit. And I'm a bit more animated. Like when I'm in a home visit, I will read what's going on. Oftentimes when I have people call me, they'll give me a heads up. I get in my specific role, I get a lot of patients in Delaware that are tied in like with Division of Aging, Adult Protective Services, or state Medicaid. So I get a lot of walks of life. I get no two stories ever the same, but I usually get a lot of info fed to me. And I will go in and I will do the best I can to break down the barriers and just put the spotlight on them. Like, what's going on? You just got out of the hospital. Why are we in there for the fifth time? The food's not that good. Like, nobody wants a turkey sandwich in the emergency department that much. I can make a better one and I'll put Old Bay on it. Sometimes you just have to get to these people and be like, what are we doing? What do you want at the end of the day? What are your key goals? And again, no two people are going to be the same. Sometimes I've had those conversations and it's just been to sit down with people to talk, and they don't need my help. Like, they don't need my services. They just need that person that's not their family member, not their friend, not somebody they've talked to before, to almost play a therapy role, to be like, what are we doing here? And move on. And I'm not sure if that helped, but oftentimes, at least from what I run into, for those that just have the fear, not sure what they're doing, that's worked well. I've done it. I have a counterpart that also covers Sussex County. She's run into a lot as well. She sometimes just does one-time meetings in person. Sometimes it's just over the phone to talk about what they might need. And sometimes people just need to hear that.
Yeah, I really appreciate the thing is that sometimes happens to me. I am a chaplain, and then when I enter to a room saying that good afternoon, I am a chaplain on call, they are thinking what happened with my kid that they don't know told me, and then it's that block, and then sometimes this kind of services is good to know in a little if the decision we need to make it in the next 3 weeks or a week or in a month, but we don't need to just say just right now we need to make a phone call and then do this, and then it's the good, try to keep this calm, but because I know it's difficult to make decisions like that, but thank you.
And especially, and bless you for what you do. I love working. I love kids. I don't know. My heart sank when I went to AI and nursing clinicals. I had the hardest time trying to even get through my clinical rotation there. And I never thought I'd have that as a weak spot. But even to relate it to like my primarily like 40 plus population, because it's a little concerning how the age has dialed down a lot of people that I'm meeting with. Oftentimes, especially like in a hospital setting, I don't know what case managers have said. I don't know what nursing staff have said. I just show up, and maybe this may help. I know it can be really tough. You made a good point saying when you go in saying you're a chaplain, it spends parents' minds running. Sometimes I've left out just very briefly like what my role is, and I have just said I was just asked to stop in and see how you guys were doing, or take whatever and run with it. And then I'll soften the blow and just say, well, I got referred to come in. It's nothing urgent. I wanted to introduce myself because I think I might be here to help you all, and it might not be today, but I'm part of your team to help you. And that's a big thing when it comes to healthcare. Every person that we work with is going to be different. Everybody's healthcare battle is going to look very different. And we all got to be there for one another at the end of the day. Everybody's just full of anxiety and trying to put on a good smile and power through every day, one day at a time. And just being there to support is what matters. But thank you for that, Nanny.
Alrighty, I'm gonna end the recording.